Hi, everybody. I'm Taj. I'm an internal medicine resident at Dalhousie University. I have a background in history, biology and chemistry, and history again. So this is my project. It's called Disposables, examining the origins of disposable gowns and drapes in the healthcare system. And I have no affiliations to any commercial interests or anything of the sort to disclose. So we all know that hospitals are a major energy consumer and producer of waste, both in the US and Canada, and disposable medical equipment contributes to a significant and increasing proportion of hospital waste. Operating room OR waste contributes significantly to this as well, with up to 70% an estimate from US hospital systems is from the OR directly. And a significant proportion of OR waste is from disposable items such as surgical gowns and drapes. Now, the majority of hospitals use disposable single-use non-woven surgical gowns and drapes, and these are made out of plastic, which is layered in different layers of fibers. And similar materials have actually been used now for isolation gowns and for the disposable gas or masks that we all wear during the pandemic. Reusable options, however, are available, mainly cotton or polyester cotton blends that can be laundered, and there's actually no difference in efficacy, cost, comfort, or any measure at all between these. And in some areas, reusables are actually superior. So the question becomes, why are we not using reusables? So this is a historical review where we attempted to answer this question by examining over 122 articles on disposable and reusable surgical gowns and drapes within an English language academic, medical, and trade journals in the 20th century. These were examined using what's called an agnotological approach, where the quality, data, and logic of each article was scrutinized. And so this is the academic discipline of examining the deliberate making of uncertainty by the subversion of science. And just to clarify, I'm only presenting several of the major, I would call them seminal studies in this field. But agnotology is the academic discipline examining the deliberate making of uncertainty by the subversion of science. And similar techniques have been used by different industries to perpetuate leaded gasoline and paint, cigarettes, vinyl chloride, climate change denial, and opioids. And it's been well documented to this effect. And you'll often have similar actors working for different industries in these categories. And so this is a historical field that really charts how these tools are made, used, and perpetuated. And my argument is that we can actually see some of these similar tools and methodologies in the surgical gown and drape debate. So how the debate kicks off is an article in 1952 by Beck and Collette. And here's a copy of the article itself. And essentially what he argues, or what they argue, is that the gown material of the time, which was essentially the same as what we use for bed linen now, was completely useless as soon as it got wet. In fact, it would actually wick bacteria from the surgeon's skin into the patient's wounds, and that they needed something in order to replace this. Now, right off the bat, a bunch of alternatives emerged. So I call what was the original material loose weave, but tight weave cotton came out quite a bit, or shortly thereafter. It was actually developed in the Second World War for fighter pilot uniforms in order to keep them safe if they were ever downed in the ocean. And it's just really tightly woven cotton that's pretty impervious to water. Disposable items emerged as well, such as treated paper, plastic film, and non-woven plastics. And a debate pretty much immediately began over which one was best. And that's where we begin to see agnotological methods at play. So I'm going to highlight several of these major issues, or several of these major methods, and kind of try and string together and give you some of the more clear examples in order to illustrate this as well, just because this project kind of got out of hand at a certain point, and going over all of it is going to be without a doubt more than 10 minutes. So one of the major ones that I kind of see are methodological issues within it. So one clear example of this is the use of loose weave as a control in studies evaluating disposable items and their efficacy. So this is despite the idea from 1952 that these items were very useless, and that's despite other options being available to use as better controls, such as tight weave reusable items. So this use of loose weave as a control when comparing to disposable items made the disposable items appear way better than they actually were. And at the same time, they would do this thing where they would just, in their articles, equivocate loose weave and tight weave to make it sound like all disposables were terrible. Sorry, all disposables were amazing and all reusables were terrible. And this is something that was very much disputed at the time. This is actually Beck in 1975 publishing another article where he's essentially calling out the industry for doing this. He's essentially saying that while he did start the debate in 1952, he wants to make it very clear that not all reusables are useless and not all disposables are automatically effective. In fact, he would in some articles describe this as a dangerous perception that people were trying to perpetuate. But this practice continued well into the 80s, the 90s, and so on. Methodological issues. This is actually an article of 1986 where you can see an author once again arguing that even in the 80s, loose weave cotton was used as the control versus disposables, which is just bad for patient care and also just extremely terrible methodologically. There's also the issue of unsupported claims. I saw this as being a major one that kind of pointed towards agnotology as well, where you have a lot of articles that would just not provide citations or linked inappropriate evidence, especially in non-medical journals, because you kind of had this debate go from medical journals to academic journals read by hospital administrators and OR nursing staff to trade journals. And you would see a lot of these people making claims that would then just get perpetuated on and on and on. For example, this article in 1979 in a academic journal in which they just, or say, an academic journal also became into a trade journal, that just the idea that any material, any stitching at all, which essentially means reusable, is automatically going to be useless because bacteria will get through the small holes in the stitching with no evidence to this claim whatsoever. And I think it's really important to note that whenever somebody makes claims like these, for example, the idea that there could be pyrogens on reusable drapes, it takes a lot more work, such as Belkin right there in 1981, to actually try and refute it. And by doing this, you can just kind of fire off whatever claims you want, but those doing good science have to put in real work in order to try and refute those claims. And it causes this issue where it's really hard to refute these ones, but you can just make whatever claims you want. And so there's just a lot of unsubstantiated claims that emerged as well that disposables had multiple benefits over reusables that they really didn't have, and also that really didn't matter all that much. These include cost, comfort, lint, convenience, and environment, and I've linked some of the major studies that are most clear in this on here. Cost was an important factor, of course, in slipping down in drape type, and intuitively switching from loose weave to tight weave is going to be fairly cheap and efficient, especially you already have laundry facilities in most of these hospitals to deal with this, instead of buying new gowns each and every time and buying full disposal systems in order to incinerate them, get rid of them, etc. However, right after this came out, and you had some authors arguing that reusables are cheaper, a lot of articles came out arguing that disposables are cheaper, and they would just hit on random things, and eventually labor costs became the real bugbear, saying that eventually labor costs in the United States would increase to the point where it would be ineffective or inefficient to use reusable gowns. Now, Beck again comes out and kind of counter this as well. For example, he's actually saying that you should not listen to any published reviews of cost, where you see a lot of very, very fancy mathematical equations being put out there that would perpetuate or that would report to show that disposables are inevitably cheaper than reusables. And what he was saying is that most of these had no evidence whatsoever. These were just made up numbers. And he gets kind of at this point a little ironic where he starts saying that some actually figure in 1/3 of a person into their cost calculations, but he's actually never seen 1/3 of a person working anywhere. It just doesn't usually happen like that. So the environment is another one of these things that kind of just started throwing out claims to. I mean, off the bat, intuitively, there's a clear benefit to reusables compared to disposables. But in the 1970s, you had a growing concern regarding pollution with the creation of the EPA, the Silent Spring being produced by Rachel Carson, and a growing and nascent environmental movement. So this is something that started to become more and more of an issue. And you had some articles mentioning the environmental impact as a pro of reusables and something an issue with disposables. And inevitably, as soon as that starts happening, you see the disposable industry start firing out studies that essentially point to poor quality articles. Sorry, essentially point to disposals being the exact same, if not a little better, in terms of environmental friendliness. Here's an article from 1993 that actually shows and I'll go into this actually in more detail in a little while, but it shows one of the similar claims where without any evidence at all, they're saying that reusable products consume significantly more water and produce more pollution, and they actually produce more volatile organic compounds as air emissions and link it to smog, essentially saying that while disposables are bad, reusables are bad, and actually a little bit worse, if anything at all. And so what ends up happening with all these claims that are kind of fired out there, such as cost, comfort, environment, et cetera, and all of this, you essentially have this effect where you have a lot of these articles that are just really badly done, poor methodology, lots of unsupported claims that just get cited and cited and cited and cited. And eventually they kind of shed all of the issues that surrounded them where you had authors trying to refute them, and they kind of take on a life of their own. And eventually they kind of just become true in and of themselves. And this amplification, as I call it, is really what makes the agnotology work. And a great example of this is a study that I just showed, the McDowell study. And this is an article by Overcash et al. In 2012, a really well done article. And essentially he kind of breaks apart the study and says this 15-page report published in 1993, but the data was unavailable. And I've had a hard time trying to track down the study myself. But one of the copies I found said that you can only get the data if you pay them $500 in order to do so. It's not exactly good science. It is also produced by Arthur D. Little. And if anybody wants any information on that company, please find me after. It's a fascinating story. One more minute. All right. And this article essentially shows that This article I showed earlier, where there was like these claims that the reusables were going to create all these issues, just got perpetuated throughout, with like almost verbatim. In 1996, an article by Goldberg et al. Again says more water used, more pollutants with reusables. 2001, the exact same kind of stuff. It says you can't really say which one's better, and you can actually see the same article published or cited as late as 2023, an article I cite myself because it's phenomenal, by Yap et al. But it actually cites the McDowell study as well, because it's still present within our literature to this day, despite it having no evidence whatsoever. And you can even see that in 1976, you had authors who were, in favor of reusables, essentially saying that this is what's happening. If you look at the last line there, has the advent of disposable devices been a response to needs or a product of marketing strategy? And I argue that the marketing strategy is what really caused this. So I argue that the technological methods appear in the debate here, and they really point towards a concerted effort to subvert science. I don't have a smoking gun, unfortunately, but eventually these do emerge, as they have in every single other field. But it is important to identify these strategies when used, allows us to mitigate them in the future, and remove bad science from current literature. But the warning I want to give is that this is something that's not just going to stop. Potential for similar events in the future means that we need to be wary of bad science being put out there, and that it is going to be a lot harder, I think, to switch away from disposable items than we realize, given the amount of money within this field. And the only thing I want to say is I feel like fields like history, which are usually left out of debates in this, can provide a lot of utility in this field in order to help us kind of understand these strategies, identify them, and mitigate them in the future as well. So here's a selection of the references.
Thank you for that outstanding presentation. As before, we'll save questions till the end, and next we're going to hear from Dr. Emily Goddard.
Hi, everyone. Thank you so much for having me. My name is Emily. I'm currently a data analyst with the Yale program on climate change communication. But this project was part of my master's degree at the Yale School of Public Health. And I'd just like to thank Rachel Hanane, who's an MD PhD candidate at the Yale School of Public Health and really spearheaded this project. And I'll be presenting our work on stakeholder perspectives on scaling up medical device reprocessing. Do I press sorry? There we go. No? Yeah. Sorry. Oh, that one. Great. Thank you. Sorry about that. So the United States healthcare sector is responsible for 8.5% of national greenhouse gases, gas emissions, and similar fractions of toxic air emissions, which in 2018 resulted in 400,000 disability-adjusted life years. Medical device reprocessing is a sustainability strategy that can decrease hospital waste, costs, and emissions, and improve supply chain resilience, which we saw was a huge issue, especially during the COVID-19 pandemic. So MDR is a third-party industry that collects single-use medical devices and then uses FDA-approved procedures to disassemble, decontaminate, refurbish, reassemble, test, repackage, and resterilize them so that they can safely be resold and reused. However, of all medical devices that are currently created, only approximately 2% can be reprocessed, and only a small fraction of those actually get reprocessed. So we conducted a qualitative study to better understand the facilitators and barriers to scaling up medical device reprocessing. We used the consolidated framework for implementation research, which is widely used for characterizing constructs that influence the implementation of quality improvement initiatives, such as MDR. It has these 5 domains: intervention characteristics, outer setting, inner setting, individual characteristics, and process, which for the purpose of this study are the aspects of MDR that influence how it's adopted, characteristics both outside of the hospital and then inside of the hospital that influence implementation of MDR, hospital stakeholders' beliefs, knowledge, and engagement in MDR, and then just the process of how MDR is implemented. So we conducted our study at the Yale New Haven Health System, specifically in the operating rooms. As mentioned, they're responsible for significant amounts of hospital wastes and expenses. And Yale was an interesting place to do this study because it does have contracts in place to reprocess certain medical devices, but it doesn't currently have a system-wide MDR program. So there's a lot of space for scaling up this program. And we conducted hospital site visits and held interviews with a variety of stakeholders, including clinicians, hospital administrators, and industry stakeholders. And then we analyzed these interviews by coding transcripts according to CFIR domains, and then adding additional codes for areas that weren't captured by the CFIR, and then conducting thematic analysis. So we identified 6 steps that were commonly used for implementing MDR, and then 5 overall themes that influenced that implementation, which I'm going to go into a little bit more detail right now. So the implementation steps, we're starting with stakeholders, typically corporate supply chain and materials management would work with third-party MDR vendors to identify items of interest and set up a contract. If that contract involves buying back reprocessed medical devices, which it often does, the vendor would stock those devices in the supply rooms. Nurses would use reprocessed devices during cases. After the cases, nurses dispose of these devices in designated MDR bins in the operating rooms. When the bins are full, aides would take those full bins to soiled utility rooms, and then the vendor picks up the bins from those utility rooms, brings them back to their facility, goes through the FDA-approved process of reprocessing, and then this process starts all over again. And so the themes that we identified from our interviews were that the FDA and original equipment manufacturers, or OEMs, really determined which devices can be reprocessed. MDR has variable compatibility with hospital priorities, some good, some bad, and physician preferences can really influence which devices are ordered. Staff knowledge and beliefs about MDR impact their engagement, and just that MDR infrastructure is really essential for maintaining these programs. So I'm going to go into a little bit more detail about the ways that each of these themes can facilitate and inhibit scaling up MDR. As far as the FDA and original equipment manufacturers, FDA approval can really legitimize MDR, and the federal government's interest in the right to repair movement, which prohibits manufacturers from banning the repair of equipment and devices by individuals and independent repair shops. And then some of the barriers are stringent FDA regulations can limit the number of devices that actually can be reprocessed, and forced obsolescence by original equipment manufacturers, who often use tactics to actually prevent health systems from engaging in MDR so that they can maximize profits. So our recommendations around this were to implement changes in the regulation process to enable more devices to be reprocessed, and also implement federal policies that can promote a circular economy in healthcare, specifically advancing the right to repair movement, expanding that to medical devices. So as far as compatibility with hospital priorities, MDR, and many of our participants noted this, can be cost saving, can increase the resiliency of the supply chain, and supports an overall culture of sustainability, which many participants said was important to their hospitals. However, also there's this perception of decreased functionality, whether or not that is actually the case. And then there's also a lack of data on greenhouse gas emission savings. So we recommend bolstering that data availability, specifically from third-party vendors, to conduct life cycle assessments and understand the total waste emissions and cost savings of MDR, and bringing that data back to clinicians, hospitals, and making that available for the people who are actually participating in the programs. On physician preferences, like hospitals, physicians, many participants noted that physicians also prioritized cost and environmental savings, but some physicians also had preferences for single-use devices, whether it was just that they were trained on them or comfortable with them. And then there's also just the logistics of changing physician preference cards. The numbers for single-use devices are often different than the numbers for reprocessed devices. Just the logistics of encouraging physicians to do that can be difficult. So we recommended inviting physicians to MDR facilities and providing them with data on the functionality, sterility, and environmental benefits and cost savings of medically reprocessed devices. As far as staff knowledge, again, increasing importance of environmental sustainability among staff was one of the facilitators. As far as barriers, a general lack of knowledge on the benefits. Again, we see this lack of data and lack of data getting to the people who are participating in the programs. And then generally just low collection rates, not knowing where to put the devices. So we recommend health system-wide trainings, posting clear signs on MDR bins, and again, providing these routine audit and feedback reports. And then MDR infrastructure. Some of the facilitators vendors do sometimes provide reports on pounds of averted waste and the cost savings of the MDR programs to the health systems. But we noted that at least in this health system, there was no MDR program manager, and the data was really lacking as far as like a complete life cycle assessment and data on greenhouse gas emissions. So we recommended hiring a full-time program manager and creating an auditing system to provide data on the full life cycle of these reprocessed devices. So our study had many strengths and limitations. I'm not going to go through all of them, but there was the potential for social desirability bias, as many of the participants knew the purpose of this study. However, many of the participants were also somewhat critical of medical device reprocessing, so we estimate that that was minimal, if at all. And then we did base this at a very large but single health system in the US. So it would be interesting to see the generalizability of the study if it's able to be done at other institutions. And so in conclusion, medical device reprocessing can have huge benefits for reducing hospital wastes, cutting carbon emissions, reducing hospital spending, and improving supply chain resiliency. And we hope that this study will support hospitals in scaling up MDR to reap those benefits. Thank you so much.
Good morning, everyone, and thank you all for coming, and thank you to the organizers for letting me speak. I know our break is coming up pretty soon, so I'll try to be relatively quick. I'm Michael Padget. I am a trained epidemiologist and have been working in the sustainability space in healthcare for the last few years, and I'm now currently at the Mass General Center for the Environment and Health. We've been talking a lot about different actions this morning that we can take to sort of make the health system and more globally the world more sustainable. And I want to touch on a question that is near and dear to my heart, which is what data do we need to help support these things? As a disclaimer, I don't have the answers, but we're making steps, hopefully, that will be useful. We've all seen things that look like this, and we saw one in the last presentation. This is carbon footprinting, the results of carbon footprinting. This one's from the NHS in England. And these are becoming more and more popular as we're trying to decarbonize the health system. So for me, these give a good overview of where carbon is coming from in the system. It's broken down by different sectors, often linked to financial records. And we can use it to set goals and maybe track our progress for decarbonization efforts. The question that I have, and I'll get to this, is how well does this link with some of the actions that we are discussing? Can we actually use this on a day-to-day basis with some of the things we'd like to do, and particularly within the healthcare system and within hospitals? I pulled this off the Healthcare Without Harm website about actions. We're all talking about actions we want to do. These are a few of them. So I'll just grab one at random. Educate your community. We've talked about educating people, educating doctors. I don't find education on this carbon footprinting. Of course, this has indirect impacts, but it's not directly measured here. What about starting a green team? Same situation, right? We have reduced OR, energy use, and water. That is probably more directly related to some of this measurement. But if you look at this, we don't necessarily have a specific OR, energy and water part of the pie. So there's obviously some actions that are more directly related with these, and you could fit them in a little bit easier. But the point is that a lot of these actions are not. And so the question is, can we have different types of indicators, different types of measurements that might be a little bit closer to the actions that we want to take and maybe more understandable? So if you tell someone we need to plant trees to reduce our carbon impact, it might be a little bit obscure. So this is one approach that we are taking at our center. Well, actually, I'll go back to this one. The carbon footprinting, I think, is a good starting point to give you a baseline of what you should focus on, and it's linked with your decarbonization goals. But as I just mentioned, it's not a great fit always with some of the actions. It's at a high level. Often it's a bit obscure, the link between this and the actions, and the historical data needed to calculate these is often somewhat outdated. Comparability can be a challenge as well, because if you know something about these types of measures, they can be different on how people are using their data to come up with these. So comparability can be an issue. We are working on a dashboard for our hospital to give not only this sort of high-level measurement, but sort of meso-level indicators that might be a little bit more closely related with the action that we're asking people to take. So our objectives for this dashboard are to have data that we present publicly that is easily understandable, and it's about things that are related to sustainability, and I'll show you some examples. We wanted to include a different range of impact because there's so many actions that we can take that one piece of data doesn't seem to fit everything. It is public facing, which gives us an opportunity to educate not just the people within our health system, but hopefully the public if they take a minute to look at what we're producing. And we're hoping we'll provide some transparency about our actions and accountability, so that we can generate some enthusiasm within the hospital, including administrators that might be interested in this topic. Also, this is ongoing work. So the data provide not only a baseline for measuring our progress, but hopefully a baseline for actually improving the measures over time. How did we do it? We first had to identify some domains. Some of these will look familiar to those of you who work with Practice Green Health, for example. But these are data that are fairly commonly available if you have a health system or a hospital of sufficient size. The data collection, we worked with an existing network that we have through our center, and we didn't want to put undue burden on these groups. Working with us and working on sustainability is not part of anyone's job description. So everything that we're asking people to do is an extra thing. We wanted to, especially at a first stage, make this as easy as possible. So we wanted to use data that already exists and they've already collected. And as I said, most of these hospitals should have already. We also wanted to work with these people to make sure that they're on board with this, that they agree with the messages that we're trying to communicate, with the way the data are presented, and the actions, because ultimately it will be these people that we rely on to take these actions in a lot of cases. And we used Tableau. Some of you might be familiar with this. I think it's pretty good. It's interactive. You can actually download the data if you go on there, and it's all public facing. So this is one example. This is a dashboard that we have on waste. It's not that complicated, but we are displaying municipal waste by month, so you can track it over time, and by site, where people are actually producing this waste. We have regulated medical waste, which is a lot more polluting, and we have organic waste, which is actually displayed by year. Now, why is it by year? Because that's the data they had. So we didn't ask them to actually break this out because we didn't want to annoy them. We have a lot of text, and this is relatively simple information for everyone. As I said, it's for the general public. So where do these data come from? What do they mean? What's the environmental impact of these things? What is being done by the hospital? And if you really want to get involved, where you can go. We have another collection of other dashboards. The anesthetic gas data has just been published. And let me go back, actually. You can actually go on here if you're really motivated. You can see this, and you can play around with the data. You can download it or click on various parts of the data to see what the numbers are. And the link is at the bottom. So the anesthetic gas data has been recently published. We have a purchasing data dashboard that should be hopefully ready to be published in the next week or two. and ongoing work on transportation data, CO2 data. We actually just did a CO2 footprinting. We're be happy to publish that as well, and energy and water use. What are the next steps for this? We'd like to add some additional indicators. We'd like to create specific targets. So our system has an overall target of decarbonization, but I think it'd be interesting to have a waste-specific target or a water or energy-specific targets. We'd like to expand this to work with other systems. I think it would be really powerful to have not only our system displaying these data, but other systems, and then you can start getting into comparability. And in a longer term approach, improve the indicators using possibly a more quality indicator approach, where you apply sort of criteria that you might use to quality indicators to these type of indicators, and have something that's useful and understandable and timely for everyone. That's it. Thank you for your attention.
Thank you. And next we'll have Dr. Emily Parker, who is online. Is that correct?
Hi there. Can you hear me?
Yes, we're just calling up your slides, or is she?
I'll bring them up.
So let me share her video. She's...
Is that showing?
Yes.
Yeah. And can you hear me okay?
Yes.
Good. Hi, everyone. My name's Emily. I am a paediatric junior doctor working in Newcastle, but I'm actually joining you from York in the UK. So from York to New York, because I've escaped some very inclement weather of Storm Babette, which is currently hitting the UK, which is quite an unusual thing to happen in October, November. So we are feeling the effects of climate change here too. I'm going to talk about carbon footprinting project that I did with a big team of people. So I just want to say thank you to all of the people who helped with this project. Their names are listed on the bottom. And it was supported very generously by the Great North Children's Hospital charity. So thank you to them. I'm really interested that, Michael, you brought up this image in your last talk. This is the carbon footprint of the English National Health Service. And I agree with your critique. I think carbon footprints like this don't do a huge amount to help us change our practice and actually cut carbon in clinical practice. So we've come from this starting point, and what we wanted to do was ask the question, what parts of this footprint can clinicians influence? And what information do we need in order to do that? So a very obvious part of this footprint that is directly influenced by clinical decision-making is medicines and chemicals. And that forms 25% of the NHS England carbon footprint. Internationally, the estimates are that it's about between 12 and 25%, depending on which health system you're looking at. But unfortunately, there's a lack of evidence as to how we can change our decision-making to cut carbon in these areas. As Michael said, carbon footprinting studies are quite detailed, they're quite difficult for clinicians to read, and they're often not really comparable to each other because they use different methodologies. So along with my multidisciplinary team made up of pharmacists, paediatricians and general practitioners, I tried to carbon footprint 2 different medicines to see what the comparison was. So working in paediatrics, one of the common situations is that medicines are prescribed as liquids, and that can happen even up to the age of about 12, 13, 14 in the UK, way beyond the age when children can learn to swallow tablets. There's many studies to show that this can be safely taught to children from the age of about 4. So what we have here is a situation of clinical equivalence. You can deliver the medicine through tablet or liquid, and it doesn't really change the outcome for the patient as long as they're able to take the tablets. But we don't know what the environmental impact is of these 2 forms of medicine. So for this study, we chose a functional unit of a 6-year-old girl who has tonsillitis. She needs 7 days of penicillin. 3 times a day, 500 milligram doses. So she needs a 21 dose course of penicillin, and we've chosen amoxicillin to illustrate this. What are we going to give her? Are we going to give her liquid? Are we going to give her tablets? This is a process map of the production of amoxicillin. So you've got the 3 different parts of the medicine. You've got the excipient, so that's everything except the active ingredient that goes into the tablet or the liquid. You've got the active ingredient itself, the amoxicillin molecule, and then you've got the packaging. And all of these have raw materials and energy that goes into their production. Then they're assembled, distributed, used, and disposed of. A lot of carbon footprinting studies are quite interesting from a clinical perspective because they actually stop when you get to the distribution stage. So, for example, the only other comparative carbon footprinting study of liquids and tablets that currently is published was done by Sherman et al. In India. And they only did cradle to gate. So they started with the production, but finished at the point of distribution. We thought it was very important to include use and disposal in our study, partly because they're areas that are kind of influenced in clinical practice. And we know that the form of the medicine changes how it's used. So we really wanted to capture that in our study. This is how medicine reaches the patient in England. I know it looks a little bit different in the US, so I'd be interested to hear about that in the discussion. But here's the packet of liquid medicine of amoxicillin and the tablet form. So to start with, what we did was we deconstructed the packaging, as you can see here. We weighed the component parts, we identified the different materials, and we used UK government greenhouse gas conversion factors to give a carbon dioxide equivalent for each of these materials. And these were our results. And this is just for the packaging, distribution, and disposal. This doesn't include the active ingredient of amoxicillin at this point. So as you can see, the carbon footprints are quite small when you just look at the packaging. But the suspension bottle does have 3 times larger carbon footprint than the packs of capsules. And actually, when you apply this to a course of 21 doses, this multiplies by 3. So it's a 9-fold difference because you have to supply 3 bottles to the patient versus 1 pack of, if you look at the bottom line, you can supply a pack of 21 capsules and that reaches the patient just in the same way. So this difference between the two is about as much as a banana, so it's not a huge carbon footprint. But one of the things that is really interesting about healthcare systems that is different from the decisions that you make as an individual is that you can scale it. So we tried to scale this and we modeled based on switching 50% of all the liquid prescriptions in one NHS region in 1 year, and that region has the equivalent population to the state of Virginia. But remember, this is only one medicine, and we found that the equivalent saving would be equal to 31 flights between London Heathrow and JFK Airport. But now we're going to add in the active ingredient. So we were lucky enough to team with UMaker, which is an amazing organization that is currently trying to carbon footprint a huge formulary of medicines. And they use a method that basically takes into account the size of and the form of the molecule. So this is a picture of the amoxicillin molecule. And they analyze the structure of that molecule and then use that to estimate the carbon footprint based on how much energy goes into the processes of making that molecule. And I've just included a paper here that looks at process mass intensity in case anyone's interested in how you use that to estimate carbon footprints. That paper evaluates that and is quite interesting read if you're interested. So when you add in the active ingredient into the calculations, what you see is that, in fact, packaging and distribution disposal are completely eclipsed by the carbon footprint of the active ingredient. So this is for a 100 ml bottle of suspension, and it's around 98% of the carbon footprint here is the active ingredient amoxicillin. And I think that's really interesting for us because often we care a lot about packaging because it's what we see, and there's a lot of publicity around plastic waste and how important that is, but that's a different problem than carbon footprint, and it's quite important for us to think about what's wasted, what the contents that are being wasted and what impact that has. So going back to the 2 forms of medicine, if you think about wastage in terms of a 21 dose course, what you can see is that with the bottle, that contains 10 doses of 500 milligrams. So there's a 500 milligram dose in every 10 mil. It's an 100 mil bottle. When you want to supply that to the patient, you need to supply the final single dose as a whole bottle that the patient will only take one dose of. There's no way of taking that dose out of the bottle on its own and giving it to the patient. Whereas with tablets, you have a 21 capsule pack. It's designed for the course, but also you can cut up the pack. So in England, it's common practice that if the course is a number that is not come in a package form that's already designed for that course, you would be able to cut another pack and supply that to the patient. And the difference, the amount of carbon footprint that is in the bottle, that wasted bottle that you give to the patient for the final dose of this course, would be the equivalent of driving 99 miles in a small car, which would get you from the Empire State Building to Liberty Bell in Philadelphia. I don't think you get there in an SUV. It would have to be a small car, but it would get you pretty far. So that's quite a shocking amount of carbon. So we thought about how this might apply to clinical practice, and we've made some recommendations. So we would recommend that you choose tablets and capsules first, if possible, that you ask your patients if they're able to take tablets or capsules, and that would also include adults, because there's a lot of evidence to show that adults also can't swallow tablets, and that affects their and if you do need
sorry, your sound cut out for a second.
Oh, sorry. Where should I go back to?
Just the top of the slide, and you have 1 minute.
Oh yeah, no problem. So we've made some clinical recommendations based on this, and these generally apply to outpatient medicine, but also discharge prescriptions from inpatients. It's a little bit different when you're an inpatient in hospital, because I think often the rest of the bottle would get used for another patient. So tablets and capsules first. Ask the patient if they're able to swallow tablets and capsules. Often we find that adults can't swallow tablets and capsules either, so ask them even if they're an adult, and consider pill training for patients who say no. There's loads of resources available online to help you do this. If liquids are required, think about the number of doses. So we would suggest that not all courses of antibiotics need to be 21 doses. You could save a lot by just prescribing 20 doses and giving 2 bottles. And then we think also better dispenser-prescriber communication. So we would like to implement a process where the dispensers can question the prescription if they see that there's a huge amount of wastage that's likely to be dispensed to the patient, and ask the prescriber if they really do want to dispense that final dose in the bottle. Thank you very much. If you've got any questions about the active pharmaceutical ingredient, please contact UMaker. They're welcome your questions. And if you're happy to fill out an evaluation, I've just put a QR code up there for an evaluation form. I'm looking forward to this discussion. Thank you.
Thank you, Dr. Parker. We're going to call up Dr. Brar again, who has one more presentation to give, and then we'll open for Q&A.
Hi, everybody. So I'm going to go over this presentation. A few weeks ago, this was one of my colleagues presenting it, just because hearing my voice twice is not the most pleasant thing. But I'm just going to go through it as best as possible. So this is a project that we're doing at Dalhousie University. I think I said earlier, Dalhousie University is located in Halifax, Nova Scotia in Canada. And we're essentially doing a case study of the environmental impacts of an MTU stay. So here is myself and my co-residents. We're all internal medicine senior residents, and then Lukeman is a medical student currently. And we have no affiliations, any commercial interests whatsoever. However, we are supported by a grant from Cascades Canada, which is government funded. So we all know that healthcare and climate change are inexorably linked. And educating medical learners in the link between healthcare and climate change is a key way to reduce healthcare-related emissions. And learners have been shown to be eager to bridge this gap through planetary health advocacy and opportunities, but there's also a feeling amongst medical students they don't always get the best training in this field, something that we need to improve on. We think that a large portion of this is due to the difficulty inherent in conceptualizing the link between healthcare practices and real emissions. And there are tools that exist to quantify these healthcare emissions, but the generalizability of these tools is unclear, as was brought up earlier in several presentations. And trying to use them in this situation hasn't been done that often before. So the purpose of this case report is to really overall develop a tool that will give learners a way to connect healthcare practices they engage in to their climate change effects. And we aim to do this via case study analyses in conjunction with a healthcare LCA database, an open source database of LCA analyses of common components of healthcare done by the University of Toronto with other satellites, including Dalhousie. We plan to use an example case study to demonstrate how this can be done by examining a typical stay in the medical teaching unit, or MTU, at the Halifax Infirmary Hospital in Halifax, Nova Scotia. This is the inpatient internal medicine ward at this hospital, and by tabulating the number of investigations, procedures, and length of stay for a patient with a typical stay, one without complications requiring a higher level of care or more advanced imaging and treatment modalities, and then cross-referencing this with the emissions data in the LCA database, we aim to provide a real value for the emissions created during this admission. And this is A, to show that we can reify these abstract values for learners, but B, we also want to figure out whether or not this is very generalizable and whether or not those values in themselves should be used to change practice per se. And this is just the very beginning of this project. We're just getting started on this. So this is a patient case. This is actually a composite patient. We have not received Research Ethics Board approval for the cases we have already done. So we're just going to present this composite done by several senior medical residents. And I'll go through it very quickly. To summarize, essentially, is a patient who came in with a COPD exacerbation, who lives with their son, has mild cognitive disorder and heart failure as well. The most important medications, they're on Trelegy and on furosemide. And they had a 1-week history of worsening shortness of breath, cough, and decreased oral intake following smoke exposure. This is something that we very commonly saw following the wildfires, which hit Halifax a few months ago, in which our city unfortunately almost burnt down as a result of climate change. So the patient also had a 3-day history of increasing leg swelling and orthopnea, had missed several days of medications because they were not feeling well, and they were found confused by their son, who called 911, and they found the patient to be hypoxic. The initial lab work wasn't terrible, to be honest, except for the BNP of 4,800. Chest X-ray showed mild pulmonary edema, and ECG showed atrial fibrillation, which was new for the patient, all in keeping with signs of volume overload. They required 5 liters of oxygen to keep their saturation up, but overall, they were doing okay vitally. They were a bit confused, like giving them a GCS of 14. So they were diagnosed by the emergency department with a COPD exacerbation, started appropriate treatments. In internal medicine, our team was consulted regarding the COPD exacerbation, the possible heart failure exacerbation, the new AFib, and we agreed with all these diagnoses, and we started them on treatment with IV Lasix. And the patient was transferred to the MTU after 2 days in the emergency department. To be honest, 2 days is not nearly as long as it usually takes for a patient to go upstairs, but it was a 5-day total stay in the MTU when they got there. They had daily blood work, 5 days of antibiotics, appropriate steroids, and they were seen by members of the allied health team. They improved quite rapidly, their fluid overload resolved, their ECG normalized, and they were eventually discharged home with son or with follow-up as needed with their existing healthcare professionals. So the main reason that we did this case is that we could get these numbers right here. We can try and figure out exactly what was ordered during these and then cross-reference those with the LCA database. And so throughout this, rough estimate would just be 6 CBCs, 1 on their initial presentation and 5 on their daily blood work, as well as several other investigations as well, with ECG, chest X-ray, and 5 days on the inpatient ward. Looking at the lab investigations, how it's done in the LCA database, as per it, it's broken down to phlebotomy, the drawing of the vial, and the test runs per tube. And this essentially comes out to an overall estimate that for the initial blood work, you have phlebotomy in the red there, which is a significant proportion of it. But interestingly enough, as per the study by Spoialo et al., almost half of that actually comes from the liver enzymes and liver function test. So a pretty significant number that we don't really see as that big of a deal because cost-wise, they're not usually that expensive. So we kind of ignore those. And then daily blood work, you can see phlebotomy is really a large portion of that. But if you actually look at it closely, urea, creatinine, and extended legs appear to be over a third of it. And those are things we do not need to order every day. But unfortunately, Halifax Infirmary, we order for almost every single patient every day. So total blood work came out to 2.82 kilograms of carbon dioxide equivalents. And there were some tests were not available in the LCA database, such as BNP troponin. Imaging, one chest X-ray is estimated to be 0.76 kilograms of carbon dioxide equivalents. Very interestingly, this is actually mostly from consumables. Consumables being the pillowcase and the linen for the patient. So that's different from each hospital. There was no data in the database for ECG specifically, but there was some stuff on ECG leads. And so in total, this came out to 6.52 for the 2 chest X-rays and 2 ECGs of just the leads. And the inpatient stay based on the LCA database numbers is 45 kilograms carbon dioxide equivalents per day, for a total of 5 days of 225. We do not include the emergency department stays. We're looking just the inpatient ward here. So total emissions for a patient of this sort, based on data from the LCA database, would show that inpatient, the actual duration of stay is by and large the largest portion of this patient's greenhouse gas emissions. In total, this is 234 kilograms of carbon dioxide equivalent, and we use the EPA calculator to essentially turn that into real units. And this showed out to be 262 pounds of coal burned, 9.6 liters of gasoline consumed, or 28,000 smartphones charged. Now, this is nice because it actually gives us real values, which we find are useful for medical learners to actually take this abstract concept and make it real. But in looking through, this also tells us that a lengthier stay would have likely meant more investigations and procedures. And as soon as you get stuff like CTs and MRIs being ordered, or an ICU stay or hemodialysis, it dramatically pumps up those numbers, which we would expect. But it really shows that our uncomplicated patients kind of goes through may just not have as many emissions as somebody who has a really complicated course in hospital. So again, this is all based on LCA database data. And the question is not this is generalizable. And as our previous presenters have kind of shown, it's not that generalizable, unfortunately. This data for the blood work is from Spoyal et al. In 2023, and this is the most likely to be the most generalizable because it was done in Vancouver, and it was done mainly looking at unnecessary blood work, which required them to actually look at the total emissions for the blood work itself, and they really focused on the emissions associated with the consumables used during this process, and excluded stuff like electricity in the hospital, which does make it more generalizable. However, each hospital is going to have different lab requirements. You're going to buy different reagents, and overall, it immediately suffers from issues of generalizability. It's probably the best of all the studies we looked at, though. For imaging, the LCA database, they use McAllister et al., which is a hospital in Sydney, Australia, and they focus on emissions per use of each scanning modality to improve the generalizability. And that's excellent, except for the fact that, unfortunately, for most of these scanning modalities, the electricity used is a major source of emissions. And for us in Nova Scotia, we have the majority of our grid being gas and coal, which is not ideal, I know, but that's going to definitely change our numbers between these two sites. And of course, there's also institutional changes as well, given cost of laundry, with chest X-ray, having laundry be the major, emissions contributor. For the inpatient stay, this is by far the least generalizable. Data from Prasad et al. In 2022 done near here in Brooklyn, New York, and they looked at just the overall, bed day emissions for their inpatient ward and their ICU as well, looking at very comprehensive, to be quite honest with you, looking at building energy use, staff commuting, food service, pretty much everything you could think of. And of course, just because of the massive differences between hospital sites and locale, not really generalizable at all. And even though if you look at it, like they use an inpatient unit that does medical, surgical, and cardiac diagnoses, percutaneous interventions, weaning from ventilators, we just do medicine. We don't know nothing else on there. So in conclusion, only the blood work is readily generalizable, but even then, it's only because we are in Canada alone, and even then, it's not that generalizable at all. So the only way that we're actually going to be able to use this data is to do LCA as of our own, but we still think that this approach has value. Because at the end of the day, it's really hard to try and help learners understand that everything we do in the hospital has a climate change effect. And by using an approach like this, by trying to get medical students to go through and actually do case study analyses of cases they're involved in, they can calculate real numbers and get an idea, even though it's just a very rough estimate of the emissions created during said stay. So there are benefits to this. And once we start doing our own LCAs and hopefully improve the generalizability of the database in general, this can have some benefits as well, where we're able to A, identify things we need to include, but B, identify areas that we could try and reduce emissions from. For example, reducing length of stay, which we actually know from previous data as well, so that needs to be brought down, unnecessary blood work, reducing ICU admissions naturally, and limiting imaging as well. So here's our references, and thank you very much.
Thank you for the amazing presentations. We started about 5 minutes late. We have permission to go about 5 minutes over, and I see there are questions also online, but why don't I start with the audience? Yes.
Hi, thank you all.
And can you introduce yourself too?
I am, my name is Lynn. I am a pediatric physician at University of California in Los Angeles. And I have a couple questions. First is for Dr. Brar, the first lecture. You know, we all care about using reusables, I assume, but there's a lot of pushback that I hear people saying, well, what about all the water and the detergents that you're using? And I would love to know what you say to that and what your explanation is, because I feel like there has to be a good answer that I don't have that I want to explain. And for Dr. Blum, I think a lot of us who have witnessed healthcare in middle and low income countries understand that they really do have wonderful and quality ways of implementing healthcare at a fraction of the carbon emissions that we use. And I want to know if you're publishing on some of those strategies that are that will be accepted in higher income countries, because a lot of times there is, I would say, an ego in high income countries, and it's hard to get the acceptance of what's the strategy. And then one thing to add for Dr. Parker, since I see a lot of pediatric and adult patients with dysphagia and often with G-tubes, that I push a lot for tablets, because for all the reasons you said, and also because they have better shelf life, they're good for travel, for power outages, and not for that they don't need to be refrigerated. And you can crush them, put them in warm water, juice, applesauce, pudding, and a lot of things that patients prefer rather than the flavors. Okay.
Thank you so much, Dr. Brar. Did you want to start? Or Dr. Blanc, whoever has the microphone.
First. So in regards to your question, that's a great one. I think that's something I'm moving more towards my research, which is taking some of the things that are used today to try and find reusables and seeing what their origins are. Right off the bat, though, I would say that, you know, it's been cited quite a few times, kind of like the original source of the whole idea that detergents and water usage and stuff actually make reusables worse for the environment. And it all comes from McDowell, and that's that's not exactly a great study. And Overcash actually in 2012 really calls that we need to stop using that article entirely. Now, can I say definitively that that's the one that's cited by everybody else as like the origin for all of this? Unfortunately not. I haven't reviewed all the literature. Most recently, that's kind of going back against disposables, against reusables. But I can say that quite a few articles have cited it. I was actually reading an article from 2014 on, I think it was breast surgery, looking at trying to change draping and gowns. And it was cited in there as being a reason to not do so, because reusables would have possibly more of an impact on, thinking that one it was used for environment and for cost, because McDowell's article doesn't just stop with environment, it goes into several areas. But I think by looking through the literature, seeing where these people are getting their data from that are, you know, claiming that reusables are worse in these ways, and then essentially saying, well, this data is actually not sound that you're basing this off of. I think that's probably the best way to do it. But unfortunately, it takes quite a bit of work, and it's easy to make claims, but it's hard to prove them sometimes.
Yeah, thank you so much for that question. I think a really interesting one. The majority of the interventions that I present, I think will not run into any sort of legislative issues or anything like that. For example, the energy related ones, I don't think will be the issue won't lie there. But for some of them, they definitely will. And there's one of the articles that I have included in the systematic review that directly touches upon this. It's an article that is that presents cataract surgery in India from a specific provider, and they compare their emissions with emissions in the UK, and they have certain practices that contribute to much less emissions. The comparison is 5% of the emissions as compared to the UK. And some of those are indeed, for example, reusing medicine vials, which is in the US not allowed in that certain setting legislatively. Their outcomes are clinically better in the article as what they present than as compared to the UK. So I think this is interesting, and this is a discussion that warrants a lot more research as well to look into should legislation be changed, and what can we learn from this example. I think
Thank you so much. And Dr. Parker, I think there is more of a comment than a question for you, but I'll sort of add a question. And perhaps just because you went so fast, we would expect the active pharmaceutical ingredient for the same dose to have the same footprint. So it's the other materials that would, and how wasteful of particular packages that would make a difference. Is that what you intended?
Yeah, so when you look at everything without the active pharmaceutical ingredient, which is what we did initially because we assumed that there would be no difference in active pharmaceutical ingredient if you were delivering the same course of antibiotics, there is a slight difference between the packaging for liquids and tablets, but it's quite a small difference until you scale it up. It looks quite insignificant until you kind of do it on a large scale. But with the active pharmaceutical ingredient, the difference comes when you dispense this course of liquid and you waste almost the whole of the final bottle. So that's why we were talking about maybe thinking of doing a 20-dose course for liquids rather than 21-dose course, because when you prescribe that final dose, you're basically throwing away the last bottle. So you waste all of the other 9 doses of active ingredient. That's what makes such a big footprint that would be enough to get to Philadelphia from New York.
That's amazing. That's amazing, Dr. Parker. And I would say that this is a common practice performed by pharmacists with chemotherapy agents called dose rounding, where they round down to the lowest whole dose to avoid such waste. Another question in the audience, Dr. Sine? Can you use the mic?
Sorry, yes. Very interesting. I'm sorry, I forgot your last name, Dr. Here. Yeah. The transparent disclosures that you're making, this is on the website, right? I can find it, right? That is very consistent with, I think, the way the entire world is going outside of healthcare, which is transparent, assured disclosures. There's a lot going on in the EU. Here, the SEC is likely to rule, which will affect publicly traded hospitals and health systems. Is there any reason why you would not engage with one of the established sustainability frameworks like the Carbon Disclosure Project or GRI to verify this data and make it so that it's obviously publicly available? But I think it would give a lot of hospitals and health systems the idea, the concept that these types of disclosures should be required as an anti-greenwashing, anti-greenwashing, anti-green wishing, anti-green hushing, green crowding, green gassing measure.
Excellent points. Thank you for the question. I think there's 2 questions within that. One is, should we engage with some of the established organizations like part of the Disclosure Project? Yes, and we actually are. So this year, however, I'm not the one who did it, so I don't know all the ins and outs. But what I understood is we recorded, but it's not public. There's 2 different ways of recording. It's not verified. So, you know, actually no more if you have additional questions. But we are starting this process. So yes, we are on the path, and hopefully that will encourage more people to do it. As far as the actual dashboard goes, the point of doing it now is to be humble. I want to take my personal goal to get as much information carbon level, leach level, water level, whatever it is. I think more data is better. And one of the goals is indeed to work with other systems that I know I've spoken with have a lot of the same data but are not public. We want to show them that yes, this is possible. No, our hospital did not explode when they showed how much energy we're using, and you should do it too. So absolutely, we need to act on this.
Thank you very much. And I have a clarifying question for Dr. Brar about the last presentation that you gave. So the healthcare LCA database that people are not aware is a really fantastic, comprehensive effort that is being housed in Dalhousie. And I do want to point out, however, that it does not provide any sort of assessment of the quality of the studies. And those studies have widely varying qualities as well as scopes, whether it's cradle to grave, gate to grave, and so forth, and makes things challenging. So for example, to say what the footprint is of a CT scan, that will be highly dependent not only on the energy source locally, but also the efficiency and the utilization of that tool. So so making such statements around the footprint of a particular intervention, for example, it needs a lot of caveats. And I just want to, if you could clarify that this is for teaching purposes.
Yes, absolutely. And that's kind of, I think, like doing this and going through and actually reading the studies that were in the database and starting to realize that, like, unfortunately, it's not nearly as little our hospitals would like. And it's not really that we can just easily use it. I say that's definitely what it is here at Halifax. We're hoping to use this as inspiration and hopefully use some methodology to do our own LCAs in order to get an idea of how these things work. But this is definitely a teaching project, and we're not going to essentially say this is definitely how much we're using right now. We're hoping eventually, though, like the LCA database, it is a really interesting project and really cool. We'll eventually get towards being that. I think over time maybe it will, but for now, yeah, this is just a teaching tool to get med students and learners engaged.
Well, and importantly, you're teaching the lessons of appropriateness of care and avoiding low value care. So it's really fantastic what you're doing. One more final question before we break. That's.
And my name is James with the DCTHE and medical student. I guess it's sort of for both the MDR talk as well as the LTA last talk, right? But obviously interested in anyone's opinions on this on the panel. Thinking about how to communicate this to our fellow colleagues in terms of whether or not it's moving away from single use OR tools or trying to communicate, right, the carbon footprint of daily CDCs versus every other day or every day or whatever. Is something like the carbon footprint something that you all feel is a piece of data that you could adequately communicate to peers? Or is this sort of more of an internal discussion that is all very useful to us to quantify and talk about, but rather we should look to other communication strategies to try to engage, our colleagues who aren't necessarily at this conference here today?
So I think one of the things that our study found in the qualitative nature of it was that there's this increasing culture of sustainability at hospitals, and a lot of the staff seem to really care about sustainability. So I think it's that is a part of it, but not the entire communication strategy. Definitely having more of the life cycle assessments and understanding of the greenhouse gas emissions, I think could help. And then of course also the methods of communication. We did a little bit of research into specifically how this could be communicated to staff to increase uptake, and found that combining verbal and written communication could be helpful. And so I think it's a combination, right? There has to be the greenhouse gas and waste reductions and tailoring that to people's desires to be more sustainable right now, and also the cost reductions, the focus on functionality of devices, cleanliness of devices, and all of that.
Absolutely. And regarding what we did with our study, we were essentially hoping to try and be able to make the numbers of these abstract carbon footprint numbers into like real figures. But it's tough. It's hard to do, and that's not what we realized while doing this project. That like the numbers, studies unfortunately aren't applicable, and going between different institutions is really tough to do. But as more studies get done, as this field develops, and we start to realize that there's just like maybe innate emissions associated with certain products, but we can hopefully move towards being able to actually translate directly footprinting to actual numbers. But keep in mind, I'm a complete novice in this area, so I think everybody else in this campus speaks a lot better than I can.
Thank you. And Dr. Parker?
I think it's a really interesting question about carbon footprints, because I think they're both a technical tool which can be used to make decisions by people who are kind of informed enough to really understand what they're talking about. But they are also a really useful communication tool that can communicate to audiences what the value of objects is. I've tried to explain what one was, because I think people find it very hard to understand that you can have a carbon footprint of a pen, that you can convert that into carbon dioxide is quite difficult for people to grasp. But when you use it as a comparative tool where you say, this much, you can drive to Philadelphia for this much energy, I think people get really shocked by it, and it is a very useful thing to use. You just have to think about how you use it for different audiences.
Thank you, Dr. Parker. And just one thing I would add is that these one-off studies are very challenging, and having performed this study with Emily Goddard, I would say that part of the reason to do so and call out is that one of the things that are challenging is that the medical device reprocessing industry does not provide any carbon data. And in fact, they don't even provide details on the amount of equipment. If you engage with these companies, get sort of a monthly or a quarterly report on volume or pounds of waste averted and dollars saved, which is kind of mysteriously calculated. But really, we really need to know more details on the amounts and types of equipment and what the footprints are, which is really dependent on the number of reuses, which is proprietary information. But overall, what is needed is per product environmental product declarations, and they're of the emissions in a standardized and transparent way. And there's a lot of movement in this direction. It's going to be some time in the making. If I would venture a guess, it would be about 10 years, but that's really what is required. We're over time. This is really fascinating, and thank you everyone for your attention. We'll continue the conversation over the break. Thank you.